Okay, thank you so much for the invite. It's a pleasure to be back here. I was here last year, speaking on the same topic, but will perhaps show some new results as well on high-resolution ultrasound. So I'm privileged to speak on this new technology that we have used on a multi-center trial. We finished that study across 5 sites, but I'll talk about imaging on using a high resolution on a 29 megahertz transducer, and we'll talk a little bit of a very initial study that we have done comparing this on, with MRI in patients who are on active surveillance. So I'm an investigator in a multi-center trial, which was funded by the industry, Exact Imaging, who have manufactured this device. So to start, what is micro-ultrasound? To those who are new to this device, it is nothing but ultrasound, but at a very high resolution. So normally, the platform that we use for a truss-guided biopsy or imaging is about 6 to 9 or 9 to 11 megahertz transducers. A micro-ultrasound or a high-resolution ultrasound allows you, and it operates at about up to 29 megahertz. So it provides much higher than conventional resolution that you see on a regular transrectal ultrasound. There is a 300% improvement in the resolution, both in the axial and the lateral planes. It enables the use of the Primus wrist identification protocol, and I'm going to talk about that a little bit as I go on the study in this presentation. The device is now commercially available and approved in Europe and in the US. So here on your left-hand side is a conventional truss, a 6 to 9 megahertz image on your left-hand side. On the right-hand side is a high-resolution image of the same prostate obtained at 29 megahertz. And you can appreciate the difference, the high resolution that you can see the urethra, you can see the ejaculatory ducts, the detail that you can see on a high-resolution ultrasound. This is just B-mode imaging on this image, but you can appreciate the difference between a regular 6 to 9 megahertz transducer and a very high resolution, to 3 times more than the normal resolution that we generally use. So not just the texture within the prostate, most of the times at the time of imaging, we visualize the neurovascular bundles. So if you are seeing a cancer and you want to stage the disease, is it involving the neurovascular bundles? It perhaps could help you in seeing if the tumor is close to or extending or involving the neurovascular bundles. And unlike conventional ultrasound, many a times at the time of the biopsy, we see old biopsy needle marks. So we have seen needle marks from a previous biopsy, which were even 2 years previously. So you're doing a scan today, you're seeing a mark of a needle mark, a hypo kind of an echoic line within the prostate gland, which correlates to the prior biopsy site. And this can really help in patients who are on active surveillance. If you knew that the right lateral base was Gleason 6 disease on previous imaging, you can perhaps point your needle to the same site at the time of active surveillance and repeat biopsies. So that can be another feature which can be very helpful if you're using this device. Just the high resolution, it enables you to see prior needle marks in many of these patients. So how did it all start? Initial study was done out of Johns Hopkins. 25 men who had already consented to a RAT-P for their prostate disease were scanned using both conventional and a high-resolution scanner before they went on to have the radical prostatectomy, and the whole mounts were compared with the images. Micro-ultrasound increased the sensitivity and the specificity significantly. As you can see, the sensitivity improved by about 73%, while the specificity for significant tumor increased by about 9 to 10%. Also, in this study of a relatively small cohort of patients, more high-grade lesions were identified on high-resolution scanner as compared to the standard low-resolution scan. So that was the initial study, after which we went on to do the prospective 2,000 patient 5-center trial, and I'll talk about that as well a little later on. So the question really is, how does micro-ultrasound play as opposed to fusion biopsy, as opposed to prostate MR followed by a fusion biopsy? We've heard a lot about prostate MR earlier this afternoon today. And if you can now, the hypothesis here is if you can now start seeing the lesions on ultrasound, which we did not see on conventional ultrasound, can you actually avoid an MR and avoid a fusion biopsy for the patient? So the advantages of micro-ultrasound are real-time visualization, so real-time targeting. You don't bring the fusion device in play at all, so there's no issues about misregistration. It's just ultrasound. You don't need an MR. Well, you may not need an MR is what I should say at this time. And it's just ultrasound with a higher resolution. And it takes just a few more minutes to perform an evidence-based Primus scoring. So Primus is nothing but a scoring risk, very similar to the PIRAT scoring pattern that we have. We were emulating the PIRAT scoring to identify the type of the characteristics of lesions on high resolution which may harbor cancer. And I'll again talk about that in just a minute. The other advantage is a single urology-based visit rather than multiple visits that one may have if you're going to do an MR followed by an MR fusion biopsy. So we did a very early 9-patient study comparing high-resolution ultrasound to prostate MR. And these patients who had already had a biopsy were patients who were on active surveillance for low-volume Gleason 6 disease, who went on to have an MR prior to their second biopsy. Well, they'd had at least one prior biopsy in the past. So the protocol included that the MR had to be done within 4 weeks of the second biopsy or the subsequent biopsy. They went on to have a conventional ultrasound with a 6 to 9 megahertz transducer, followed by the micro-ultrasound scan. So till this time, the operator was blinded to the MR report. After scanning the patient with the conventional ultrasound, followed by the high-resolution ultrasound, they were unblinded to the MR. So the blinded reads were made on the conventional and the high resolution, and then they were unblinded to the MR. And at the time of the biopsy, all the data was taken into account before doing the biopsy. So if a lesion was seen on the high resolution, they had a targeted biopsy of that site. And after unblinding of the MR, if there was anything that was not seen on ultrasound, either of the 2 ultrasounds, the protocol included that those sites would also be biopsied. So the idea was to provide all benefits of all the 3 imaging devices to the patient. So of the 9 patients, there were 2 lesions in the same patient which were seen on conventional ultrasound. So I'm talking about significant cancer, so we're talking about Gleason 7, 3+4 or higher. There were 2 lesions which were seen on the conventional ultrasound. Now, were also seen on the MR. So I have the high B-value weighted image and the T2 as well as the SAG images there. So what was seen on conventional ultrasound was also seen, the bottom two images were also seen on MR, but there were two other lesions which were seen on MR, which were clinically significant disease, which were not seen on the conventional ultrasound. So that's the added benefit of MR on the conventional ultrasound, and that's what we've been discussing today so far. And all the four lesions were prospectively seen on high-resolution ultrasound. So the two lesions which were seen on conventional ultrasound were also seen on the high-resolution ultrasound, but the other two lesions which were seen on MR were also seen on the high-resolution ultrasound. So they were prospectively seen, biopsied, and were clinically significant cancer. As you can see there, one was a Gleason 9 and the other was a Gleason 8, the lesions which were not seen on conventional but were seen on MR and high resolution. But there were these four lesions, again, a small cohort of study. These four lesions, which were not seen prospectively on MR, were not called a para 3, 4, or a 5 lesion on MR, but a targeted biopsy from these sites on high-resolution MR showed clinically significant cancer. As you can see, four of those lesions were Gleason 7, all four of them. So four lesions which were not seen on MR were picked up on high-resolution ultrasound. They were small lesions, but they were 3 + 4, all four of them. The cancer core length, I think, was about 2 millimeters in most of them, but the size of the lesion when we measured on imaging was about 6 to 8 millimeters on four of them. The range was 6 to 8 millimeters. So and we had two separate readers for MR. I'm not going to go into the inter-observer variability in MREs. I think we know about that. But if you look at this, there were four lesions which were picked up on MR and ultrasound, micro-ultrasound, but there were four lesions which were clinically significant, Gleason 7, were not picked up on MR. Again, a very early study, just 9 patients, but it does show that high-resolution ultrasound may have the capability of picking up smaller lesions which could be missed on MR. So we did go back retrospectively to the MRs to see, did we actually retrospectively see those lesions or not? And when we went back, we could not call those lesions. These were small lesions. We could not call those lesions. I could perhaps call 2 of these lesions as a para 3, but because they were not seen on the high B-value images, I could not label them as a 4 or a 5, even retrospectively. These were peripheral zone lesions. They were not seen retrospectively on MR, but they were small lesions. Again, very early study, only 9 patients at the time. So micro-ultrasound was more sensitive to clinically significant cancer, and again, a little different definition of a clinically significant cancer, as we were discussing earlier. Any volume Gleason 4 component we considered that as a clinically significant, especially based on the long-term active surveillance data that we have now from Laurie Klotz's group and some other studies coming out. So any volume Gleason 7 perhaps may be an important clinically significant lesion. So, so the 3 patients highlighted in yellow, patient number 3, 5, and 6 in this small cohort of patients. 3 and 5, the highest Gleason grade was picked up on MR and high-resolution ultrasound, but was in patient 6, that the lesion was not picked up on MR. We did see Gleason 6 on the opposite side, on the contralateral side, but the right lateral apex small lesion, which if I were to go back, was actually the bottom right lesion, the lesion in image D, which was not picked up on MR, was a Gleason 7, a different patient. There was no other biopsy was positive in this patient. So it did make a difference to this one patient. So again, so the initial feasibility study comparing micro-ultrasound to MR, it may have a role to play, but I think we do need a larger multi-center trial to see its benefit. It is very early to say that it may see all lesions that were seen on MR. So the next question that comes in is, how difficult is it to interpret micro-ultrasound images? This is much more detail that we are seeing. We're not accustomed to seeing images at 29 megahertz. And that's what happened to us when we started doing the study as part of the multi-center prospective 2,000-patient trial that we've just concluded. How do urologists or clinicians interpret this level of detail? So we put forward the evidence-based protocol, the Primus protocol. I'm going to talk about that a bit. Again, that's the first version. I'm sure as more users use this device, there's going to be subtle changes. There are going to be new versions which are going to come out as we gain more experience in this device. Very similar to the PIRATs. Is it difficult to learn? I would say no. We did a validation study, and I think I'll go to the next slide to talk about all that. So early on, we knew that the anatomical detail that we were seeing, it was very frustrating for us, how to interpret the images. As residents, as radiologists, we've been taught, aim for the hypoechoic area. But we were seeing much more than just hypoechoic areas within the prostate on this high resolution. And we didn't know where to put our needle. So after having done a few biopsies, we went back, we reviewed the images correlated with pathology. We knew that there was a need for an evidence-based protocol. So what we did was we came out with a Primus protocol, which was developed using a blinded reading of over 300 images, correlating that to pathology, and then calculate the relative risk ratios to determine which features were associated with cancer on the high-resolution scanner. So there were some features that we labeled as a Primus score of 4 or 5, which were more commonly associated with cancer than in features, and some other features which we label as Primus 1, 2, or 3. Comedonecrosis, as you can see in the top left image, areas of calcification more commonly associated with cancer. Many of these patients came back as Gleason 7. The bottom right image, you can see alternate hypo and hyperechoic bands with some posterior shadowing. One could call it a tiger stripe, a zebra pattern, again, more commonly associated with cancer. The top right, we call this a smudgy or a cauliflower pattern, as you can see, predominantly hyperechoic with some hypo bands between them, like a cauliflower kind of a pattern, again, more commonly associated with cancer. And then the bottom right image, you can see there is central echogenic area with the margins being more hypoechoic, again, more commonly associated with cancer. So this is the resolution that we were seeing with the micro-ultrasound, which we were not appreciating with the 6 to 9 megahertz transducers. And that's why we didn't know where to put the needle in initially. Once we started recognizing these patterns, it just became much more easier for us to know as to what could be cancer on the high resolution and how to interpret the images. So still very early on, and I'm sure we're going to tweak the Primus protocol as we carry on, as we gain more experience with high resolution ultrasound. So once the Primus came into place, so I'm not sure if this video will run. So I'm sorry, I'm having some IT issues here. Yeah, that's good. So you can see the comedonecrosis on your sweep. So you see that calcific area, hyperechoic area, and this was a site of either Gleason 7 or Gleason 8, I don't remember, but this was prostate cancer. Again, so these were features that we were not seeing, and again, a second site in the same prostate, very similar appearance. These were features which we were not identifying when we were using a conventional ultrasound. And so that's what led to the development of the Primus scoring, very similar to the PIRAT scoring, Primus 1 to Primus 5 score. The higher the score, the higher the chances of harboring clinically significant cancer. And we based the second half of our study on Primus. So prospectively, we would call out a Primus score at the time of the biopsy during the second half of this 2,000 patient cohort of patients study that we concluded. And we still have not got our results back. I think we've concluded the study, but the results should be due in the next month or so. So once we had developed the Primus, we went on to validate that with only 1 hour of training. All investigators, there were 5 investigators, 2 urologists in that group, 1 radiologist, 1 sonographer, and 1 physicist, so a very heterogeneous group of clinicians and paraclinicians here. who used the Primus protocol to detect cancer in the cine loops, which were kind of saved from the initial half of the study. And we found that increasing risk score predicted higher Gleason score and higher percentage of core involved as well. So the learning curve was not very steep. It was not very onerous once we knew what to look at. So again, benefits of micro-ultrasound as a targeting tool. Access to MR may be an issue, will be an issue in many parts of the world, in the Western world as well. Optimized or standardized reporting will also be an issue, or at least at this stage is an issue. Can high resolution help us to some extent in closing that gap? There are other disadvantages of MR, if I can say. Multiple patient visits, there's a cost effectiveness. I know there are some studies which have come out recently which do show that MR may be cost effective, but it is an easier process to have a high resolution ultrasound done in a single clinical setting. There is a learning curve, but I don't think it's a very onerous learning curve. In a couple of hours, one can identify, a couple of hours of dedicated training, one can start identifying the lesions which may be significant, or at least what we know at this stage. So really, it's an ultrasound-based, clinic-based, a single instrument, perhaps a single visit to the clinic, and those, I think, are the biggest highlights. If on a multi-center trial, we can actually duplicate the results that we initially showed on a very small cohort of 9 patients. Thank you.